Welcome to our video on sepsis, toxic shock syndrome, and fever of unknown origin. Let's begin. As the name of the lecture implies, here we will cover sepsis, toxic shock syndrome, and fever of unknown origin. Let's start with sepsis. For sepsis, we'll discuss the definition, causes, clinical presentation, diagnosis, and management. Before going any further, it's worth mentioning that systemic inflammation and infection are classified into these 5 states: systemic inflammatory response syndrome, also known as SIRS, sepsis, severe sepsis, septic shock, and multiple organ dysfunction syndrome. Let's talk about the definition of each of these states. Systemic inflammatory response syndrome, also known as SIRS, is diagnosed if the patient meets at least 2 out of 4 SIRS criteria. These criteria include a temperature less than 36 degrees Celsius or more than 38 degrees Celsius, and a white blood cell count less than 4,000 or more than 12,000. The alternate for the white blood cell count criteria is the presence of bands more than 10%. The other 2 SIRS criteria include a heart rate more than 90 beats per minute and a respiratory rate more than 20, or a partial pressure of carbon dioxide less than 32. If the patient meets any 2 out of these 4 criteria, they're considered to be SIRS positive. Please keep in mind that systemic inflammatory response syndrome does not necessarily suggest an infection. SIRS, or SIRS, can also be caused by systemic diseases like systemic lupus erythematosus, rheumatoid arthritis, inflammatory bowel disease, and so on. This is one of the reasons that SIRS criteria is slowly falling out of favor as a way to identify patients with sepsis. Sepsis is defined as systemic inflammatory response syndrome positivity along with a suspected or confirmed source of infection, such as a catheter. We'll talk more about the causes of sepsis later on in this lecture. Severe sepsis is the sepsis accompanied by hypotension and hypoperfusion. Hypoperfusion can manifest either with lactic acidosis, systolic blood pressure less than 90, or the drop in systolic blood pressure by at least 40. The septic shock meets the criteria for severe sepsis, but additionally it is characterized by hypotension refractory to fluid resuscitation. Finally, the most severe condition on the spectrum of sepsis and related states is the multiple organ dysfunction syndrome. Multiple organ dysfunction syndrome is the presence of objective evidence of at least 2 organ failure. For example, increased blood urea nitrogen and creatinine may suggest the acute kidney injury, while simultaneous rise in liver function tests and coagulation parameters may indicate the acute liver failure. The causes of sepsis can be broadly classified into 3 main categories: localized infection followed by dissemination, iatrogenic causes of sepsis, and trauma. Infections commonly implicated in subsequent sepsis include pneumonia, acute pyelonephritis, and enterocolitis. The main iatrogenic cause of sepsis is the presence of central or peripheral venous catheters. This is because the bacteria of the normal skin flora can attach to the catheters by producing the biofilms and enter the bloodstream. Trauma causing open contaminated skin wounds or burns can also facilitate bacterial introduction into the bloodstream. As we mentioned on the previous slides, sepsis usually presents with fever and hypotension. Additionally, the patients commonly have symptoms specific to the particular organ system. If pneumonia is the trigger of sepsis, the patient may present with productive cough and purulent sputum. Acute pyelonephritis can manifest with dysuria and flank tenderness, while the catheter site infection will present with redness and swelling on the catheter insertion site. Diagnosis of sepsis is established clinically by identifying SIRS positivity and the suspected source of infection. Confirmatory investigations include blood cultures and organ-specific cultures like that of sputum or urine. Management of sepsis includes initiation of empiric broad-spectrum antibiotics immediately after obtaining the blood culture. Additionally, most patients require aggressive intravenous fluid resuscitation. Vasopressors, like norepinephrine, may be needed if the patient is unresponsive to intravenous fluids. A 70-year-old woman is brought to the emergency department due to acute confusion that started 3 hours ago. She has had productive and purulent cough with high fever for 3 days. Lung auscultation reveals decreased breath sounds and increased tactile fremitus at the right lung base. Her vital signs are significant for severe hypotension with tachycardia. Laboratory findings reveal lactic acidosis. What's the best next step in the diagnosis of this patient? This patient presents with acute confusion. She's had productive cough with a purulent cough and high fever for 3 days. Lung auscultation reveals decreased breath sounds and increased tactile fremitus at the right lung base. These findings are consistent with the diagnosis of right lower lobe pneumonia. Her vital signs are significant for severe hypotension and tachycardia. Lab findings reveal lactic acidosis. These clues suggest the diagnosis of severe sepsis secondary to pneumonia. The best next step in the diagnosis of sepsis of any severity is blood culture and should be obtained before initiating antibiotics. Here's a table summarizing criteria for SIRS, sepsis, severe sepsis, septic shock, and the multiple organ dysfunction syndrome. Please take a moment to consider this table. Let's move on to the toxic shock syndrome. For toxic shock syndrome, we'll discuss its definition, causes, pathophysiology, clinical presentation, diagnosis, and management. Toxic shock syndrome is the toxin-induced overstimulation of immune system. It is associated with prolonged use of vaginal tampons or nasal packs. 2 bacteria are implicated as the causative agents for toxic shock syndrome. The most common bacteria causing toxic shock syndrome is Staphylococcus aureus. Streptococcus pyogenes typically causes the toxic shock-like syndrome. Let's briefly discuss the pathophysiology of toxic shock syndrome with the help of an illustration. Overgrowth of Staphylococcus aureus on vaginal tampons or nasal packs results in release of toxic shock syndrome toxin 1 or TSST1. Toxic shock syndrome toxin 1 cross-links the macrophages and helper T cells outside the antigen binding site. This causes diffuse, nonspecific T cell activation and results in cytokine storm with interleukin-2, interferon gamma, and so on. These cytokines are responsible for the signs and symptoms of toxic shock syndrome. In general, a patient is suspected of having toxic shock syndrome if they present with fever, hypotension, and features of multi-organ failure with or without rash. Here we discuss the 5 clinical criteria for the staphylococcal toxic shock syndrome. First, the temperature should be at least 38.9 degrees Celsius. Secondly, the patient should have diffuse erythematous macular rash. Third criterion is the skin desquamation, which may be observed 1 to 2 weeks after onset of rash. Desquamation may not always be seen because the patient might die before the rash starts to desquamate. Fourth criterion is the hypotension. In adults, hypotension is defined as the systolic blood pressure less than 90. In children less than 16 years of age, hypotension is defined as the systolic blood pressure less than 5th percentile by age. Here we see the desquamating rash in the patient with toxic shock syndrome. Please note this diffuse macular erythematous rash and this patchy desquamation developing after several days. The 5th criterion for staphylococcal toxic shock syndrome is involvement of 3 or more of the organ systems that we will discuss in this and the next slide. Gastrointestinal symptoms include vomiting and diarrhea. Muscular signs and symptoms include myalgia or serum creatinine kinase elevated to more than 2 times the upper limit of normal. Mucous membrane involvement is typically seen as oropharyngeal, vaginal, or conjunctival hyperemia. Hematologic manifestations of toxic shock syndrome include the platelet count less than 100,000. Additionally, acute renal failure in the context of the toxic shock syndrome is suggested by elevation of blood urea nitrogen and creatinine to more than 2 times the upper limit of normal. The patients with toxic shock syndrome may also have pyuria, that is more than 5 white blood cells per high power field, in the absence of urinary tract infection. Hepatic involvement presents with transaminase or bilirubin elevation to more than 2 times the upper limit of normal. Finally, the central nervous system dysfunction manifests with disorientation or altered consciousness with no focal neurologic deficits. In order to diagnose the staphylococcal toxic shock syndrome, the patient should meet both clinical and laboratory criteria. Now that we've already discussed the clinical criteria for the previous section, let's discuss about the 2 laboratory criteria. First, blood and CSF cultures should be negative for alternative pathogens other than Staphylococcus aureus. However, the blood culture may be positive for Staphylococcus aureus. Secondly, the serologic test should be negative for leptospirosis, measles, and Rocky Mountain spotted fever. The probable case of staphylococcal shock syndrome is the case which meets both laboratory criteria and 4 out of 5 clinical criteria. In contrast, the confirmed case is the one which meets both laboratory criteria and 5 out of 5 clinical criteria. Here is the table summarizing clinical and laboratory criteria for staphylococcal toxic shock syndrome. Please take a moment to consider this table. For the management of toxic shock syndrome, intravenous fluids should be administered urgently to support the patient's blood pressure. If the patient is unresponsive to IV fluids, vasopressors like norepinephrine should be administered. Initiation of empiric broad-spectrum antibiotics immediately after obtaining the blood culture is necessary. Empiric regimen includes vancomycin plus clindamycin plus 1 of the following: penicillin beta-lactamase inhibitor or cefepime or carbapenem. Intravenous immunoglobulin may be useful in streptococcal TSS. Finally, dialysis is initiated in case of renal failure. A 25-year-old man presents to the emergency department with altered mental status. He was involved in a fight 3 days ago, and he has needed to use nasal packs since then. His vital signs are significant for high fever, hypotension, and tachycardia. Physical examination shows diffuse macular rash. Liver function tests, blood urea nitrogen, creatinine, and creatinine kinase are severely elevated. What is the best next step in the management of this patient's condition? This patient presents with altered mental status, high fever, hypotension, and tachycardia. The physical exam shows diffuse macular rash. Liver function tests, blood urea nitrogen, creatinine, and creatinine kinase are severely elevated. He was involved in a fight 3 days ago, and he has needed to use nasal packs since then. All these findings, along with prolonged use of nasal packs, are consistent with staphylococcal toxic shock syndrome. The best next step in the management of this patient's condition is obtaining blood cultures, administering IV fluids, and initiation of empiric antibiotics. Let's finish off this lecture by discussing the fever of unknown origin. For fever of unknown origin, we will discuss its definition, classification, causes, diagnosis, and management. Fever of unknown origin is the temperature more than 38.3 degrees Celsius, lasting more than 3 weeks with no obvious source despite intensive investigation. There are 4 types of fever of unknown origin: classic, nosocomial, neutropenic, and HIV-related. Classic fever of unknown origin is characterized by fever more than 38.3 degrees Celsius, lasting more than 3 weeks. Fever should be present on at least 3 outpatient visits or at least 3 inpatient evaluations. Nosocomial fever has the same temperature cutoff value, that is 38.3 degrees Celsius. In this case, the patient should be hospitalized for at least 24 hours with no fever or incubation period on admission. The fever should be present on at least 3 inpatient evaluations. Neutropenic fever of unknown origin is temperature more than 38.3 degrees Celsius with the absolute neutrophil count of less than 500. Again, fever should be present on at least 3 inpatient evaluations. Finally, HIV-related fever of unknown origin has the same temperature cutoff value. However, in this case, the fever should last for more than 4 weeks in outpatients and more than 3 days in inpatients. Additionally, HIV infection should be confirmed. Let's talk about the possible expected causes of each type of fever of unknown origin. Classic fever of unknown origin is most commonly caused by malignancy, infection like tuberculosis, or the collagen vascular disease like systemic lupus erythematosus. Nosocomial fever of unknown origin is typically caused by clostridioids, difficile enterocolitis, septic thrombophlebitis, or sinusitis. Neutropenic fever of unknown origin is mostly due to opportunistic bacterial infections, aspergillosis, and candidiasis. Finally, the HIV-related fever of unknown origin is usually caused by HIV-associated infections like cytomegalovirus infection and pneumocystis pneumonia. Kaposi sarcoma and lymphoma can also cause HIV-associated fever of unknown origin. In order to diagnose the fever of unknown origin, all the other known causes of fever should be excluded. This is why detailed history and physical exam are essential to diagnose the fever of unknown origin. From the history, special emphasis should be placed on the travel history to screen for tuberculosis, occupation and animal exposure to check for zoonotic infections, and the family history of malignancy to screen for cancer. Physical examination focuses on lymph node, liver, and spleen palpation to check for lymphadenopathy and hepatosplenomegaly. Additionally, the pulmonary auscultation can give clues about possible lung infections like tuberculosis or aspergillosis. From the laboratory tests, complete blood count is important to check for the leukocyte count and differential. Blood culture may identify the causative microbe of fever of unknown origin. PPD test screens for exposure to tuberculosis. Anti-nuclear antibody can be ordered if autoimmune condition is suspected as the cause of the fever of unknown origin. Imaging studies include chest X-ray to check for infectious pulmonary foci. Abdominal ultrasound or CT scan can be done if abdominal infection or malignancy is suspected. Ultimately, biopsy can be performed if malignancy is strongly suspected. Management of fever of unknown origin focuses on treating the underlying cause. Otherwise, antipyretics like acetaminophen or non-steroidal anti-inflammatory drugs can be used symptomatically for high fever. Let's end this lecture with a board-style question. A 69-year-old man presents to the emergency department with agitation. He has had pain on urination for 4 days. Past medical history is significant for benign prostatic hyperplasia. His vital signs include a temperature of 40 degrees Celsius, blood pressure of 68/50, and heart rate of 130, and respiratory rate of 24. Physical exam is significant for left-sided costovertebral angle tenderness. His lab findings are significant for leukocyte count of 30,000. Blood culture was obtained and empiric antibiotics, along with aggressive intravenous hydration, was started. Several hours after intravenous fluid administration, the blood pressure is 70/52. Blood urea nitrogen and creatinine are elevated. Which of the following is the most likely diagnosis in this patient? A. Systemic inflammatory response syndrome. B. Sepsis. C. Severe sepsis. D. Septic shock. E. Multiple organ dysfunction syndrome. This patient with past medical history of benign prostatic hyperplasia presents with agitation, pain on urination for the past 4 days, and left-sided costovertebral angle tenderness. These findings suggest the diagnosis of acute pyelonephritis. Considering his high fever, tachycardia, tachypnea, and severe leukocytosis, he meets all 4 criteria for systemic inflammatory response syndrome. He has severe hypotension and a suspected source of infection, which is the urinary tract. Therefore, he meets the criteria for severe sepsis. His initial blood pressure was 68/50, and his recent blood pressure, after several hours of intravenous fluid administration, is 70/52. This is a negligible change in blood pressure. Therefore, his sepsis is refractory to intravenous fluid resuscitation. Severe sepsis, refractory to intravenous fluid resuscitation, is the septic shock. Therefore, the correct answer is option D. Here is a table summarizing criteria for SIRS, sepsis, severe sepsis, septic shock, and the multiple organ dysfunction syndrome. Take a moment to consider this table. Let's discuss why other options are incorrect. Option A is incorrect because although this patient meets all criteria for systemic inflammatory response syndrome, he also has hypotension and suspected source of infection. Option B is incorrect because although he meets sepsis criteria, he also has hypotension, suggesting that he has at least severe sepsis. Option C is incorrect because although the patient meets severe sepsis criteria, his blood pressure is refractory to intravenous fluid administration. This latter is the criteria for septic shock. Finally, option E is incorrect because this patient exhibits the signs of only the acute renal failure evidenced by elevated blood urea nitrogen and creatinine. In order to diagnose the multiple organ dysfunction syndrome, the patient should have at least 2 organ failure. And that concludes our lecture on sepsis, toxic shock syndrome, and fever of unknown origin.